Okay. So let me give you, I want to walk you through what I would do if I had an issue. I'm going to verbally say this, but I'm literally going to write this down on a piece of paper. But if you want to take some notes, I always encourage that. Because when you actually write things, um, there is a checklist in my head. Now, what we're eventually going to do is create some type of monitoring cheat sheet or some cheat sheet for you to have in surgery rotation, because nobody has issues. Like I said, I had a girl that she put the cheat sheet on a clipboard. She put one side on another. And so when she was doing anesthesia, she could literally lift up her sheet and look at her notes. That is completely appropriate. And eventually this will become second nature and you don't have to look at the cheat sheet as much. That's the goal. But pulse oximeter is used by a lot of people, but it can give you these funky readings. And how do I know that's not true? And how do I troubleshoot the problem? You always can talk to your doctor, but I always go through a checklist. Like I said, I told my boss the dog was, I thought he was going to die at pulse ox of 90. The probe was on the floor. Had I gone through the checklist, I wouldn't have had to alert my boss and get him all freaked out. But what I start first is the first thing I check is the probe. And this kind of leads to instrument use. Is it on the right spot? Is it in feces? Didn't it fall off? The other thing is to clean the probe. Like I said, sometimes it develops like a film because people use it from one patient to the next and don't clean it in between. Also moisten the tongue. When you have a dog laying there under anesthesia and their tongue is sticking out of their mouth, it gets really dry. Sometimes I take a wet gauze square. Sometimes I've been in surgery and all I have is my little hep saline syringe from my catheter. I just squirt a little saline on their tongue. I moisten the tongue and I put the probe on. And a lot of times that does the trick. So I like moisten the area and I move the probe. Like I told you, if I get like 92 in 3 different spots and I've cleaned the probe, then I'm kind of like, okay, maybe it's not a probe issue. So the next thing I go is there an issue with my oxygen getting to my patient? So now I check my oxygen source. Do I have oxygen? Is it running? Is my tubing hooked up correctly? And this is all real quick. I can eyeball. I look at my gauge. I have oxygen. I look at my flow meter ball. It is on. But think about the flow of oxygen. And when I have a problem with a patient, this is important to understand. When I have a problem with a patient with oxygenation or breathing, there's 2 sides to the equation. Is the oxygen getting to the patient? And then is the patient using the oxygen I'm providing? And right about the point of the endotracheal tube, okay, if everything is fine with my machine, my oxygen, my probe, my endotracheal tube, then the oxygen's going inside the patient. Now, what is happening inside the patient? If you see where I'm getting at, I can kind of check everything on this end. So I check my oxygen source, check your endotracheal tube. When you guys do dentals, and a lot of times people get, they twist the dog all kinds of different ways, like upside down, move his head. And sometimes that endotracheal tube gets bent or tubing gets bent. And sometimes that's the problem, is the oxygen is being obstructed, okay? You can actually disconnect. So you're going to have a breathing system. We haven't done machines yet and all this, but you're going to have a breathing system hooked up to the endotracheal tube. If I disconnect that, do I feel air coming out of my tubing, if that makes sense? And then I've got the endotracheal tube. Sometimes I put my hand or I'll put my face right in front of the endotracheal tube. Do I feel them breathing on me? Okay, because cats can sometimes get a mucus plug. They produce a lot of mucus during intubation, and sometimes a little bit of that mucus can get stuck in the tube and they can't breathe. I mean, there's been times where I've had to re-intubate an animal during surgery because the tube became obstructed or something happened with the endotracheal tube. I've literally had to pull it out on the table, intubate them upside down during the procedure because they're in the middle of surgery. I can't move the patient. I got to be like you know? So think about, and then is the oxygen getting to my patient? Now, if everything is okay there, my probe, I've checked that, I've checked my oxygen, I've checked my endotracheal tube. Now the oxygen is going into the lungs. Is the patient able to use the oxygen I'm providing? So are there any issues in the lungs? Is there any pneumonia? I had an old, they called me in the neurology department. They were having trouble with this dog on a ventilator, and they were having trouble with oxygenation. And this dog, I had to like push the ventilator. Everything was okay on the ventilator, the oxygen. Then I was like, what's up with this dog's lungs? So when I increased pressure in the ventilator and I increased the rate, his oxygen improved and his CO2 went down. And the doctor then goes, well, yeah, on x-rays, his lungs are a little constrictive. He maybe had some scar tissue or had maybe a previous pneumonia. When he healed, it formed some scar tissue. So his lungs weren't very stretchy. They weren't compliant. So it required me to push more oxygen to the patient. So one thing I do is, if I've checked all that, when you bag your patient, when you squeeze more oxygen, does it go up? If that makes sense. Because maybe what's happening is the lungs aren't inflating enough. So I check probe, I check oxygen source, and then I check my patient. Now the last part, I can, if I increase ventilation, and if I bag the patient, and I've turned up the oxygen and bagged the patient, if that's not improving, then there's something called VQ mismatch. I'll type this. Okay, the only thing that I literally probably as an anesthetist cannot fix is if I have a patient that has VQ mismatch. That is ventilation to perfusion. So when you push oxygen to the lungs, there's a capillary surrounding every alveolus. What that means is either in that alveolus or there's some issue with the capillary where they are ventilating but they are not perfusing, meaning the oxygen is not diffusing into the blood and it is not getting to the tissues. If you have a clot in your lungs, if you have a dog with heartworm disease and it throws a worm clot where some of the worms dislodge into somewhere in the pulmonary tree, what that means is that the blood flow to that area of the lung is disrupted, or somewhere that oxygen flow to the capillary is obstructed. So this could be like an embolism. It could be a collapsed lung. If the dog had like a collapsed lung, then that lung is not perfusing. But do you see how I went through a checklist? The very last thing that I really cannot do anything with is that VQ mismatch. Then we have to get into more testing, potentially waking the patient up, potentially, doing some radiographs after surgery, CT, you know what I'm saying? So does everybody understand kind of the flow? Now, you're fine. Yeah, for you people, this is being recorded. So if you're having Zoom issues, I apologize. Let me give you a scenario. When you have an animal intubated on an anesthetic machine, you are providing oxygen. They shouldn't really be having breathing difficulty. If you notice a change in their respiratory pattern, like abdominal breathing, or you're getting a bad pulse ox reading, or they start doing that, then we have to investigate. So I had a dog, so I used to have to go take dogs anesthetized down to radiology at Purdue. So I had 2 vet students, and I had 2 dogs anesthetized on anesthesia gurneys getting radiographs. So I'm going back and forth, checking on these dogs and these anesthetists. And these are senior vet students, so they're in their 4th year. And I have one calling me, Christine, come in here. When I go in the room, the breathing bag on the machine was like giant. It was hard as a rock and it was swelling. And the dog was on the table going, He was turning blue and he was like, and I'm like, he can't breathe. And this bag is about ready to burst. So the very first thing I did, because very quickly I got to figure out why this dog can't breathe, I thought something was plugged in the machine. I thought the air was not moving in the anesthetic machine. But the way I discovered it is I disconnected the animal from the machine, because if the machine was locked up, I had to get the dog off that machine. But when I disconnected him, he was still blue and gasping for air. He was like, and I was like, his tube is clogged, like he can't breathe. And right there, it told me it wasn't a machine issue and it wasn't an oxygen tank issue. So do you see, now I have a patient. So the first thing I went to do was like, I thought his tube was clogged. He was like a 6-year-old lab getting ear radiograph or skull radiographs. So I'm like, okay, maybe he got a mucus plug. So I go to there's a little cuff that you fill up on an endotracheal tube, and it has a little valve. And I went to do this, and I had to deflate the cuff to pull the tube to put a new one in. And when I deflated it, it shot the plunger of the syringe across the room. Like I just put it in, and it sounded like a pop. And all of a sudden, the dog goes, gets pink. I hook him back up. He's breathing 100% normal. And so I kind of started talking to the student, and I said, okay, well, what was happening when you were in here? Well, she was listening. You have to listen and bag the patient to see if there's a leak. And she heard air, so she kept filling up the endotracheal tube cuff. She ended up, now a 12 mil syringe, she did about 12 of those syringes. She kept filling up. I said, how many times did you do this? And she was like, I kept filling the cup, filling the cup. Well, what happened, I think, is that here's the trachea, here's the tube, and then the cuff fills up. Well, she was filling it up so much that the end of the cuff covered the end of the tube, so the dog could not breathe. And when I deflated the cuff, it released the pressure and he could breathe again. Now, it was a mistake because I told her, I said, you should never have to use 12 syringes to fill up a cuff. I mean, it was an honest mistake, but the first thing I did was I disconnected the animal from the machine. Because if it was a machine issue, the dog would have been breathing normally as soon as I disconnected him. But when I disconnected him, it didn't fix the problem. I go, it's the dog. It's either inside the dog or the endotracheal tube. It's not my machine. So if you are getting into an issue with a patient that is having difficulty breathing, that is a really quick way to figure out, is it a machine problem or is it a patient problem? Because I've had machines lock up. I've had machines, I had to take a dog off a machine in the middle of surgery because the student closed the pop-off valve and then she couldn't get it back open. And I had to try to go get a wrench. Well, in the meantime, the bag is filling up and the dog can't breathe. So I'm like, you got to get the patient off the machine. I rolled in a new machine. I'm like, we can fix the machine later. So when we get into machines, I'll talk about that. But that's one way to troubleshoot, because, again, these readings can get you kind of panicked. And I want you to know how to work through the problem. Does anybody have any questions about pulse ox? Now, when I talk about pulse ox on a test, I'm going to be like, help me troubleshoot. What, if it's oxygen, I bag, if it's low, I bag my patient. I moisten the probe. I move the probe. I check my endotracheal tube. I check my machine. So there's like a checklist that we'll go over. Now, the other thing that we're monitoring, ventilation does lead to oxygenation. Oxygenation, though, also has to do with perfusion. Now, ventilation is basically, we know that anesthesia depresses ventilation, right? Because they're not going to breathe as fast and they're not going to breathe as deep. They are respiratory depressed to the degree, hopefully, that does not interfere with body function. We know we're going to slow it down. So how do we know that ventilation is adequate? One thing that you're going to watch is you're going to watch the patient breathe. Okay, you're going to watch them. Now the issue is you've got those drapes over the patient. If you've got a little 5-pound cat under that giant drape, you can either like pick up the drape, or you're going to have that bag on the machine that is going to, they're breathing from. So I watch my bag. I try to watch my patient. That endotracheal tube that's in their mouth, it actually fogs up. So when they breathe, you can count the fogging. You can count 1, 2, 3. You can watch the back move. You can watch the chest move. Now, you can listen. The esophageal stethoscope is in the esophagus, but the esophagus is in the thorax. So you can listen through an esophageal stethoscope. And then I'm going to talk about the respiratory monitors. But when we talk about the basics of keeping it safe, it's like you have to get oxygen in the alveoli and you have to get CO2 out the other way. So ventilation is the actual movement of the gas. Respiration is where you get the oxygen actually moved to the tissues and you move carbon dioxide out of the way. So ventilation facilitates respiration. I mean, we use those terms interchangeably, but you have to get the air in, get the CO2 out, but then it has to exchange in the tissues and the cells. Now, what we need to do is we first get a respiratory rate. Ready, breaths per minute. Now, again, you can look at the bag, you can look at the fogging in the tube. Now, the capnograph, we're going to talk about a capnograph, which is right here. It hooks up to the end. Sorry, there's a pause. It hooks up to the end of the tube, and when they breathe in and out, it'll trace on your monitor, so you can use that to count. It should be lower, but let's talk about tachypnea. So tachypnea is a fast respiratory rate. Panting is obviously faster. It'd be very rare. A patient shouldn't pant under anesthesia, okay? It should be countable. Now, why does this happen? One thing is surgical stimulus. If Dr. Ritz is like clamping the ovarian pedicle or she's clamping the spermatic cord during a neuter, a lot of dogs will sometimes like react to that and it gets faster. So sometimes it's pain or surgical stimulation, which you may have to turn the patient up. Sometimes it can be from pre-existing pulmonary disease, which hopefully we picked up on our physical exam. Hypercapnia. Does anybody know what hypercapnia means? Yeah. Yes, when you see CAPN, CAPNA, is pertaining to CO2. So hypercapnia is an elevated CO2. What happens with tachypnea is a lot of times they're fast, but they're shallow breathing. They're not like fast. This is hyperventilation. I get a lot of people and they're like, what's the difference between hyperventilation and tachypnea? Tachypnea is a fast, shallow breathing. Hyperventilation is a fast, deep breathing, okay? If an animal has a high CO2 and sometimes they're too depressed, they try to speed up their respiratory rate to get rid of CO2, but sometimes they're not breathing deep enough. So they get this tachypnea or a fast, shallow respiratory rate. Because remember, this goes back to anatomy. 40 is a normal CO2. 40 millimeters of mercury is normal. If it's elevated, the brain's normal response to an elevated CO2 is to do what to its respiratory rate? If the CO2 is elevated in the body, what should the respiratory system do? What should the brain tell the body to do if CO2 is too high? Increased breathing. Good, guys. Okay. So now, please understand what I'm about to say. When an animal is depressed under anesthesia, and certain drugs that we use depress the brain's ability to respond to that, okay? So normally in an awake animal, 40, anything above 40 should trigger this increased rate and depth of breathing. But if I've got an animal on all these respiratory depressant drugs and they depress CNS function, sometimes CO2s get in the 50s or 60s and the dog doesn't change its respiratory rate. So that's why we breathe for them. That's why we may increase our breathing, because I know the CNS is not in a great spot to respond to that. Dogs that are on high, MMHG, Michaela, that should be 40 mmHg, millimeters of mercury. Thank you for mentioning that. So I will say dogs that are on a lot of opioids like morphine, hydromorphone, fentanyl, all of those drugs, basically, they diminish the body's ability, the brain's ability to compensate for CO2. I've had dogs with CO2s in the 80s or 90s that were on heavy opioids, and the dog was not changing his respiratory rate. Now, the dog felt good. He had pain relief, but I had to ventilate that dog a lot more often to try and bring that CO2 down. And then I've had some dogs, this is really cool. I had a really good GDV once. Bloodhound. It was kind of a cute story because the week before, this bloodhound was owned by a firefighter, a volunteer firefighter. He was search and rescue bloodhound. He had gone to a seminar about GDVs for people that had police dogs or search and rescue. And so they told these guys that own these dogs, this is what you watch for, blah, blah, blah. He was at home. Dog started salivating, non-productive vomiting. He's came in really early. I'll never forget this case. And the dog had found a kid in the woods the week before. So the dog actually had done its job. It was search and rescue. A little kid wandered off in the woods. This bloodhound found him. So, our hearts are warmed because I'm I got a real service dog here that did his job. And the dog was early GDV, and we take him into surgery. And when I'm doing anesthesia with him, his CO2 would start to creep up in the 50, 55. And I was getting ready to bag him, and he'd go, and I was like, okay. And then his CO2 would creep up, and I was going to go to bag him, and he goes, so he was doing that sigh breath under anesthesia. Now, it was a good anesthesia because he was not respiratory depressed to the point where his brain couldn't respond. He did great during surgery. I remember sleeping with him on a mat at I was supposed to go home at 2 a.m. We did this surgery about 1:30 in the morning. I didn't leave my shift till about 5 a.m, which was fantastic because I was going home to young kids. But I was I laid with this dog while he was recovering. He did well. So it was just this, good thing, but it was good. It was kind of cool to see him under anesthesia adjust for his CO2. I did, so patients are going to be different. And it all depends on how they respond to these respiratory depressant drugs. And when we go over the drugs, I'll talk about the ones that are my red flag drugs, so to speak. So now tidal volume, which I always had you guys calculate this in anatomy, which is the amount of air moved in one breath in and out. You can kind of observe to get an idea of tidal volume. If they're breathing deep, they have a high tidal volume. If they're breathing shallow, they have a low tidal volume. Now, there is I've never used it, as much anesthesia as I've done, and, being at Purdue, we never used a respirometer, but because it adds another piece to the machine, and sometimes the anesthesiologist, he didn't want it to interfere with ventilation, but it measures tidal volume. You calculate it as 5 mils per pound. So tidal volume is 5 mils per pound. I'll write that down. So, you know, in our example that I've used in anatomy is you have a 40-pound dog, 5 mils times that, the dog is 200 mils tidal volume. So tidal volume is in mils. Now, hypoventilation is going to give me a subnormal or a low tidal volume, and which is shallow breathing. Hypoventilation is usually breathing not deep enough or not often enough. What is atelectasis? So atelectasis, think about it this way. If you've got a sponge, which is the lung, and it doesn't have enough air in it, or is not expanding and contracting, basically all these little alveoli are starting to collapse. And basically, atelectic is an area of non-functional gas exchange. If your lung has atelectasis, it is not exchanging oxygen. Now, if I have a dog not breathing deep enough or often enough, the consequence is atelectasis because that lung isn't getting inflated. So how do I fix that? I bag my patient, gentle bagging. There's a lot of opinions about this. Mine is the only one that matters right now. I say bag the patient every 3 to 5 minutes, regardless during anesthesia. Patients should be bagged every 3 to 5 minutes. So bag every 3 to 5 minutes during anesthesia. That helps because I know that my patient's respiratory depressed, no matter what they're doing, and they could have a beautiful CO2. Even though that bloodhound was breathing very well for this surgery, I still supplemented him because I knew he was depressed. He was respiratory depressed. He's not breathing as often. I know he's going to have areas of atelectasis. I'm going to do it right off the bat. Now, the worse your patient is breathing, the worse the atelectasis, high CO2. So how do I fix atelectasis and CO2? I bag my patient. I bag my patient. I bag my patient. If there's one, well, there's lots of things I want you to know before you're done with me, is because I talk about this with horses, and I had students at the end of 2 terms with me that still couldn't tell me what atelectasis was, and it makes me want to put my head through a wall. Because it's worse in horses, and it's very critical in horses. It's very critical to perfusion. It's why we put horses on ventilators. They don't breathe well when they're anesthetized. So, you know, hypoventilation can lead to high CO2. Why do we put horses on ventilators? Or why do they have more atelectasis? With horses, it's due to their positioning. So when a horse and their weight, when a horse is on its back for like a colic surgery, it's Michaela, it's because when they hypoventilate, they have more weight on their diaphragm because of their large intestinal tract, and they have more weight because of the size of their body. So if you think about a horse, they would have to breathe pretty deeply to expand, and they have more lung tissue. Remember, a horse thorax is bigger than a dog. Well, I mean, it's bigger because they're a horse, but a horse has 18 thoracic vertebrae. They have more lungs. So when a horse doesn't breathe well, it doesn't take long for atelectasis to kick in because of the weight, because of the positioning, and because of the procedure. So the minute a horse is asleep, they are put on a ventilator, and they breathe for them the whole surgery. So to hopefully prevent atelectasis, because it increases perfusion and oxygenation. Okay, so hopefully that answers your question, and we'll get into that. Trust me, I will. When we talk about the horse, I spend a lot of time talking about that. Now, hypoventilation is subnormal low breathing. You fix that by bagging. You can also turn your patient down because they may be respiratory depressed. Now, what do we do if they're hyperventilating? That means they have an elevated tidal volume, Now this is what happens. Now they're breathing fast and deep. So I always want students to know what is the difference between tachypnea and hyperventilation, because both are a rapid rate. The difference is tachypnea is shallow, hyperventilation is fast and deep. Usually that hyperventilate, if there's a, if they get light and they feel something during surgery, they're going to be, or if they have a very elevated hypercapnia, if they have an elevated CO2, they might try to hyperventilate to bring that CO2 down. So those are things that affect tidal volume. Now, one of my key things that I told you is the effort required to breathe, or respiratory character. Because to be honest with you, sometimes I could give two you-know-whats about their respiratory rate. I mean, it is important. I have dogs that are breathing 6 times a minute during anesthesia. That's pretty low, but good CO2, good color, good SpO2. Whatever they're breathing is matching their vitals and they're doing fine. So what you're going to do is going to watch the movement and get an idea of the character. Remember the time relationship, the IE ratio. Yes, Katie, you're correct. That's the difference. Now, remember the IE ratio, inspiratory to expiratory ratio. It should be 1:2 or a 1:3. Now like I said, this is how I breathe. I don't know if you guys remember, did you guys have Jory Wood, Miss Wood? Okay, some did. And she would be in surgery with the students, and she had a really, because this is my pet peeve. When a student goes to bag a patient, this is what they do. They close the pop off, not everybody, and they squeeze the bag and they hold it, and then they let it go. And I go, do you know what you just did? Is that how you breathe? No, this is what you do. So Jory used to tell the students, she goes, take a deep breath with your patient. First of all, it helps relax you because you're stressed doing anesthesia. So what you do is you close the pop off and you, with your patient, go, that's all you do. You just, okay. So think about how your patient is breathing. Is that ratio change? Remember I said in respiratory distress, that flips. A lot of times they get this. My dog that couldn't breathe on the Purdue story I told you, that dog was gasping for air, okay? So you want to measure the time relationship. You want to look at the effort. Listen for anything that's harsh, squeaking, whistling, crackles. Do you hear anything? If they have dyspnea, that it's labored or they're having difficulty. What I want to mention something, and does everybody know what apnea means? Means they're not breathing. Okay, if a patient has apnea, so dyspnea, PNEA, is difficulty breathing. Apnea is lack of breathing or no breathing. Now, I will tell you that sometimes patients take long pauses between breathing, but there is something called an apneustic respiratory pattern, because ketamine is a drug that causes this. And if you use ketamine, sometimes what happens is the dog will actually do a normal inhale. They'll kind of, it's like they do an inhale and they hold it. That's why it's called apneustic. It looks like apnea, but they will actually, there is a pause between inhalation and exhalation. So when I talk about ketamine, I talk about this apneustic breathing pattern. A ketamine, Ashland, causes this. On slide 65 at the bottom, it says apneustic respiratory pattern. when you give it, sometimes when you use ketamine, they will do this breath holding. It's kind of like they go, it's not difficulty breathing. It's like a jerky kind of, but the problem is sometimes you watch the dog and they pause, or they took the breath and then you go to check the patient because you turned around and they look like they're not breathing. Well, they just are holding their breath. We had a teaching lab at Purdue, and it was for tech students. We had 3 dogs anesthetized with 3 different drugs, one with pentothal, one with propofol, one with Ket-Val, and I was in the back, and I had another instructor run past me asking me where the Dopram was, which Dopram is an emergency drug. It's a respiratory stimulant, and when he ran past me, I was like, what do you want Dopram for? And he goes, the dog up there's not breathing. Where's your emergency drugs? And I'm like, whoa. I'm like, this dog was fine just like a few minutes ago. Well, when I walk over to the dog had a massive blink. Like the dog's eyeball was like open. When I went to try to open the dog's jaw, it was like a lock. And as soon as I went to open that dog's jaw, he snapped his mouth shut and he went to flip himself up in the air. Now, this is a dog they thought was anesthetized and was not breathing because he was almost dead. This dog jumped off the table. I threw myself on the dog. I held his mouth shut and I'm like, get me more drugs, get me more drugs. And we re-knocked him out. Well, the thing was, is he was doing this apneustic, like hold his breath. So they thought he stopped breathing. This dog was so light. I've seen dogs like this that are light that sometimes don't breathe. And I think because they still have a little bit of swallow or they're too light, they feel the endotracheal tube in their throat and they don't want to breathe. And there is a little bit of that reflex there. When I have a dog that does this, where I think they're holding their breath or they're a little light, sometimes I take my endotracheal tube and I move it back and forth a little bit and it causes a tickle and then they go, because they feel me move it. And then when they go, they start taking in the gas and they start breathing. Or sometimes I massage their throat a little bit because that's just ketamine. They retain some reflexes, and I think that's what leads to this apneustic breathing pattern. So that was a situation. I had a girl do that to me at VCA. She had a dog in CT land, and she practically turned the dog off because she thought he wasn't breathing and he was too deep. And what was ironic was this girl used to like think everyone else did a bad job, or she would put other people down. When I got to call her on this, I was like, I walk in there and I'm like, your dog's about ready to jump off the table. Your dog is holding his breath. He's not breathing because he's too deep and about to die. He's holding his breath because he's about to wake up. And I had to give more propofol and get him. It was a very similar situation. So I've seen these dogs, but you know what that person didn't do and the other people didn't do? They looked at one parameter. They looked at breathing. They did not check the jaw tone. They did not. All I had to do with both of those dogs was feel their jaw and look in their eyes. And I'm like, your dog is awake. Your dog is about to be awake. And you looked at one value. If you would have tried to open this dog's mouth or look at his blink or feel his muscle tone, it would have told you. I mean, I can see where they're coming from. I'm not completely slamming them. They made an error. But I'm telling you is if I don't have a dog that's breathing because he's about to die, he's not going to have jaw tone and he's not, do you see what I'm saying? Trying to paint a picture. So in both of those situations, so this apneustic pattern, it is not apnea. It is breath holding that looks like apnea because they're holding their breath. If you look long enough, they eventually have to breathe because they're not dying, they're just holding their breath. So does anyone have questions about that? Did I explain the difference between tachypnea and hyperventilation and apneustic versus apnea? Absolutely, Michaela. Character tells me a lot. Now, rate, if they're breathing fast or they're breathing slow, that rate tells me things. Rate tells me, if they're nice and slow, they're probably deeper. If they're faster, they're probably getting lighter. But character is what clues me into problems. When character starts to change, sometimes it's an indicator that my oxygenation is changing or my CO2 status is changing. So, and when they get very close to death, we talked about stage 4 and getting too deep, when the diaphragm starts to take over because they're getting way too deep, it gets to be more of a choppy, strange, the character changes. That's why when you watch your patient, you should honestly be bored doing anesthesia. It should be like everything's ticking along. They're breathing the same. It lulls you into a pattern, and that's good anesthesia. I mean, I kind of like exciting anesthesia, but that's just me. But I like, if it's boring, my patient's probably following a pattern. Now, when we get into monitors, that's all listening and hearing and feeling for you, everything that I talked about. There is something called an apnea monitor. I've never used one. I've seen clinics that have these. They basically hook up. Well, let me show you the picture. Okay. It's a little apnea monitor. You can set when you want it to alarm. So basically what it does is, here's a dog asleep. There's the endotracheal tube. Here's an adapter. This is the breathing system. So this is where the oxygen and gas come in, and you put it in between the two. So what it's detecting the change in air temperature. Okay. So right here's the sensor. The lapse time is the seconds in between the breaths. Now you can set it to when you want it to alarm. How many seconds in between? So if a dog is breathing, however often a minute, you can set it to alarm, and all it's going to do is give you like a loud alarm. I mean, if you're monitoring your patient, you don't necessarily need an apnea alarm. The only thing it's going to tell you is if they're taking too long to breathe. Now, if your respiratory rate starts to go down, this will alarm because they're not breathing enough. Okay, but it only helps you, trigger if the animal is not breathing. That's the only thing that an apnea monitor. What you really want to get into using, this is probably always, I love esophageal stethoscopes, but if I have to pick a mechanical monitor that's my favorite, it's capnograph. End-tidal CO2. It tells me a lot about my patient, but it's telling me what they are inhaling, what CO2 concentration they're inhaling, and what they're exhaling. And what they have found when they've done research is that the end-tidal CO2, they'll take an arterial sample, and it's pretty closely matches what they get from an arterial sample and what's being exhaled. So they are fairly accurate. Should an animal be inhaling more CO2 or exhaling more CO2? Right. So what you're going to do is, let me look at this a second. It's kind of hard to see on this screen a little bit, but what you have here, now this is a capnograph by itself. At school, they have an ECG monitor that has SpO2, CO2, it's all in one, okay? So you'll have a line on that monitor for your capnograph. Right here, it's telling you have 10 breaths a minute. So a capnograph will give you respiratory rate. It will give you an inspired, it's hard to see on here. This is your exhaled or expired CO2, which is 38. So this dog's doing pretty good, 38, right with our unit. It will also give you an inspired CO2. So if you look at this little graph right here with me, you have 0, and then you have your high. This might go up to 80 or 90. When the animal inhales, we want it to be at the bottom because we don't want them inhaling 0 to 2 is 0 to 2 millimeters of mercury is normal inhaled or inspired CO2. Okay. So inspired CO2 is 0. When the animal exhales, do you see how this goes up? So it's a graph, CAPNO graph. When that goes up, that is exhaled or expired CO2. So it always goes, so 0 to 2 is normal for inhaled or inspired. Exhaled, I've told you, should be 40 millimeters of mercury. So basically, it gives you the respiratory rate, it gives you the end-tidal CO2. Now, right on here in my notes, I wanted you to know 40 is the absolute normal. What's this space? Oh, that's a bar. That little, that runs. It's just because they took a picture, it froze. There's basically, as they inhale and exhale, that bar moves. So it'll kind of like keep, that's just a pause in the graph. That has nothing to do with the patient. That's the monitor itself. Now, it's explaining there's 2 types of capnographs. Side stream is probably the most normal that we use the most often. Do you see how here's the adapter and the stream is coming out the side? So what happens is when the animal exhales and inhales, but basically exhales, a little bit of that exhaled air is going to go in through this tubing into the monitor. It's going to be sampled every time they inhale and exhale. So yeah, so then when the animal inhales, see this breathing tube? This is coming from the anesthetic machine. If you've ever looked at a machine, when you've seen us at school, there's a little canister. It looks like it has like gravel, like white gravel rocks in it, or if you've worked at a clinic, that is called the soda lime. And when an animal breathes in and out through an anesthetic machine, that canister, those little granules, absorb exhaled CO2. So when the animal inhales again, they don't re-inhale CO2. So say, for example, I had an inhaled or inspired CO2 of like 10, 15, 20. I'm like, why is my animal inhaling CO2? It could be that those granules, those have to be changed on a regular basis. If those granules are expired, it may be that when the animal exhales CO2, it's not being removed and it's going back to the patient. Okay, so a capnograph is important to tell me my inspired CO2. And generally, most people say if you have a patient that's going, I think 55 is getting too high. If you have a patient between 35 and 50, you're in a decent range of CO2. When you start getting 55, 60, 70, like I said, I had a patient once was up to 90. The dog was severely respiratory depressed, and eventually did fine after surgery. It was just during surgery, I was like, holy moly, this was a lot. Okay. So yes, yes, Joycelyn, 35 to 50 is the range. If I asked you an absolute value, like what is the number, 40 is the number that, and it is millimeters of mercury. That's, I gotta mute everybody. Okay, so if we look at this, the waveform is, well, you know what? I want to talk about this because it's normally, I know it's almost 11, or I want to spend a little more time talking about this. So let me stop here. Does anyone have any questions about what we talked about so far today? I'm going to work on the SpO2 picture, and I'll be getting out that the SpO2 picture and work on our normals list. for as we finish up, I'll do that. Wait, let's see if Crystal emailed me back or messaged me. Okay, I haven't gotten anything back from her. So I would just contact her directly via school email and see what she wants to do. So I'll work on that. If you don't have any other questions, I have to do some puppy intervention. And once I do that, I will come back and work on some more work stuff. All right, well, you guys have a good day, and I will see you